Yes, ma'am.
Okay, let's begin our today's session. Welcome to the Neurosurgical Case Room. This is a continuation of the ventricular module that we have been doing for the past couple of sessions. And a day before yesterday, we covered the anterior interhemispheric transcallosal approach. And I have always found it fascinating that the transcallosal approach is basically a main highway. You get through it into the ventricle, and then there are 3 or 4 other routes that you can take in order to access the third ventricle or wherever your pathology is. 2 of these routes we have already discussed. Broadly, obviously, it won't be possible to cover them in depth, the interfornasal approach and the transforaminal approach, but we have discussed them broadly. These are the other 2 approaches, the transchoroidal and the subchoroidal approaches, which lead us to the third ventricle. But obviously, the indications are different. The contraindications are different as well. And we are going to discuss them. So before we move on, we have actually covered the lateral ventricle anatomy and the third ventricle anatomy as well. But we did not delve deeper into the choroidal fissure anatomy. So we are going to orient ourselves, and you will have to use your imagination because obviously we don't have the cadaveric dissection going on at the moment. This is how your first impression is going to be once you take off the calvaria and you do an interhemispheric approach. For both of these approaches, the transchoroidal and the subchoroidal, you are going to need the interhemispheric transcallosal corridor, right? So imagine that you have dissected. This is your cadaveric specimen. You have taken away the calvaria, and you are dissecting deep into the depths of the interhemispheric fissure. The first image is a zoomed out image. The second image, which you see here, this is a zoomed in image of interhemispheric corridor. And we have discussed this thoroughly in multiple sessions so far. You can see the corpus callosum here. You can also see the distal ACA. They are only saying ACA. This is basically distal anterior cerebral artery and pericallosal arteries, which are part of the DACA. So you see both of those. And we know that our goal is going to be making a small incision here. I'll mark it, this orange thing, roughly around 2 centimeters. This is going to be our callosotomy. Callosotomy is basically a window. We are breaching part of the roof of the lateral ventricle, and we are entering into it so that, we can gain access to the pathology beyond. Are you all with me so far?
Yes, ma'am.
Yes. Okay. So this is the next step of the dissection. You would have to imagine that you have done the callosotomy here. You can see the margins. Obviously, this is a cadaveric section, so they have taken a liberty of making a bigger callosotomy than the usual. Usually, we do it 1 to 2 centimeters. This is a cadaveric section. You can see quite a big callosotomy. Because it is big, the lateral ventricle is visible beautifully inside. Once you zoom in even further, imagine that, and this is under your microscope. Now you're zooming in from the interhemispheric fissure through the callosotomy into the lateral ventricle. This second image, this image B, let me mark it here. This is going to be your view. You will see the foramen of Monro. And we know this portion, the anterior and the superior portion, columns of the fornix. Inferiorly, somewhere here, we will have the thalamus. This is the body of the fornix. Let me change the color, and this is the fornix, okay? The body of the fornix, which is dividing into 2 columns anteriorly and going like this in a lateral direction and inferior direction as well. So it bends like a column. Here it is a solid body. The other side of the fornix has also been attached to it, but then they separate in 2 columns. This column curves around here. We know this. We have discussed this copious number of times by this point. Then apart from that, you also see choroid plexus. And you know the site of attachment of the choroid plexus is choroidal fissure. Then you see on this other side, laterally, you see the thalamus. By this point, I am sure you are all very well aware of this anatomy because we have done this a number of times. This is our thalamus striate vein. This is our superior choroidal vein because this is going to be our area of interest. Let's zoom in even further. Now you would have to imagine that you took off the entire axial section of your cadaveric specimen. And now you're looking at both of the lateral ventricles simultaneously. This is not going to be your view, obviously, when you are operating. When we are operating, we are only going to see on the one side. This is a cadaveric view, and you can see how beautifully the entirety of lateral ventricles, especially the body, the frontal horn, and some portion of the atrium is also visible. On the floor, you see the thalamus here. I'm sorry, I think I marked wrong. This is fornix. Both of these structures, thalamus is laterally placed here. And you see this pinkish structure, which is our choroid plexus. And it is also attached to the choroidal fissure, which is going anteriorly to the foramen of Monro, opening into the third ventricle. This is another view. I included similar images just so that you can imagine how it would look if we keep on zooming in. So you have now zoomed in. This is a zoomed out image. You have now zoomed in only on the lateral ventricles. You do not see any cortices here. All the structures that we have discussed so far, they are perfectly visible here. Okay, before we discuss the next image, imagine that this line here, this is the choroidal fissure. Choroidal fissure is where our choroid plexus attaches. Now it has two leaflets, one on each side. What is on the medial side? What is this?
Fornix.
Fornix, right?
The fornix, yeah.
Yes. So the layer of ependyma that attaches on the side of the fornix is going to be called tinea fornicis, or tinea fornix, or whatever you want to call it. Then there's going to be another layer because this is a fissure, right? There's going to be the second lip here. The second lip is attaching itself to the thalamus. So the other lip is going to be tinea thalami. What I want you to imagine, if you cannot at this point, is a river with water in it, okay? And there are two banks. Let's make these grassy banks here. If you imagine it this way, the river itself is going to be the choroidal fissure, right? The water is going to be the choroidal plexus. Am I making sense? We need to differentiate between both of them. So you would have to imagine that the river that is flowing, the bed inside, even if you take out the water, there's going to be an empty bed, right? That empty river or that empty bed is the choroidal fissure. The water inside or any substances inside is going to be our choroid plexus. And then we have two grassy banks on each side. And these grassy banks are named different structures. On the medial side, because that grassy bank is attaching itself to the fornix here, this is called tinea fovea, the tinea fornix. And on the other side, it is attaching itself to the thalamus. So it is tinea thalami. Are you all clear with the concept?
Yes.
This is the image that you're going to see once you open up the midline. Have you ever wondered what would happen if you separate this structure where my cursor is? What are you going to see? You are going to see a membraned structure, which is called the Velum interpositum. And what it does, what it contains, it will have the internal cerebral vein and the posterior choroidal arteries here. These are our posterior choroidal arteries. And this dark blue structure here which are paired ones. These are our internal cerebral veins. Why is this important? Because there are times when you would need to dissect down the velum interpositum and open it up when you are exposing the third ventricle. This is the choroidal fissure. You can see a small glimpse of choroidal fissure because the choroid plexus is slightly on the side. You can see this small space here, the riverbed technically, this here. This margin here would be the tinea thalami, and this margin here on the other side, where the body of the fornix is, that would be tinea fornis. That is, if you look at foramen of Monro, you can see that there is some continuation here because this choroid plexus is moving anteriorly. So what happens? There are these two spaces. Let me clear these. This is one space. This is the other space. This orange line, you will have to imagine that this is tinea thalami. The pink line is the tinea fornicis. What happens is if we open up the pink line along the fornix and we go deep down, we will end up enlarging the foramen of Monro. So this is an approach which is used sometimes in addition to the transforaminal approach. You are approaching the lesion via the foramen, but you're also opening this tinea fornicis here. And once you open this up, you will end up enlarging the foramen of Monro and hence enlarging a natural corridor. So somebody is asking in the chat box, velum interpositum, its relationship with the third ventricle. It is in the roof of the third ventricle. Let's go back. What do you see here? What is this structure?
Choroid plexus.
Right? And what about this one?
The thalamus.
That's
The
right.
thalamus.
That's the thalamus. And the fornices will be somewhere around here. We cannot accurately localize them, but they would be somewhere here, right? What do you see here? What is this? These two paired structures. These are the paired internal cerebral veins, right? These are our paired internal cerebral veins. Anteriorly, you can see the anterior septal vein. Here you can see the thalamostriate vein. They're making the venous angle. And this is labeled, but you cannot see the foramen of Monro, which is right behind this label, where this venous angle is occurring, and both of them drain into internal cerebral vein. This structure, which is communication or a continuation of pia mater, this structure is called velum interpositum, and this makes up the roof of the third ventricle. If I go even deeper, if I split it open using microdissection, then I am going to land into the third ventricle, especially the middle and the posterior third. So this is a sagittal view of everything that we have seen so far. This was our axial view. We were looking at a structure from the top. This is our sagittal view. You're looking at it, not exactly sagittal, this is a lateral view. You're looking at it from the lateral perspective. From the lateral side, if I stand on the lateral side of the patient and I take away all of the cortices above, and all I see is the lateral ventricle, medial portion, floor and the medial portion, because this is the floor. This is the thalamus and the floor. And here, this is the medial portion. You can see the fornices. You can also see the internal cerebral veins because the fornices have been opened. And you can see the choroidal fissure here, this entire thing. This is the choroidal fissure, along which you can also see that the choroid plexus is attached. Now notice that this choroid plexus is still attached to the thalamus because they have only opened the tinea fornicis and they have not opened the tinea thalami. There are combined approaches where you can open this corridor as well, but let's not go there today. Once you open this, the tinea fornicis, once you open this up, you're going to encounter this velum interpositum, which is visible here, this whitish thing. This is our velum interpositum, which contains the paired internal cerebral veins along with the posterior choroidal arteries. Is that clear?
Yes.
Now you would also have to imagine, if I clear all of this, if you remember me mentioning something in the previous slides, this approach is sometimes used to widen the foramen of Monro. You can see the foramen of Monro here, and this is the internal cerebral vein. But if I open around this line here, open it wide enough, I will gain some access and some, enlargement to the foramen of Monro. Let's move on. Since we have done the anatomy, it's time to come back to the approach. Tinea thalami forms the thalamic border. It's just a fancy word to mention or to label where the choroidal fissure or the choroidal plexus attaches to the thalamus. The thalamic border or the thalamic bank is the tinea thalami. The fornicial border is the tinea fornicis, and the choroid plexus is attached on both sides, medially to the tinea fornix, laterally with the help of tinea thalami. When we are discussing the transchoroidal corridor, it begins when we increase our exposure by dividing the tinea fornix. We have already covered that so far. We divide the tinea fornix. Once we divide it, we open up that natural corridor, and the tinea thalami that attaches the choroidal plexus to thalamus, that is not opened. So if I were to open, let's go back. If I were to open only the transchoroidal corridor here, I would use my micro dissection on this border only. Is that clear?
Yes.
Let's go back. So we only open the tinea fornix. We do not open the tinea thalami. And yes, we discussed this before. Sometimes this corridor is also used to widen the operative window of the foramen of Monro. If you don't want to compromise the fornicial column, which is going on the anterior and the superior portion of the foramen of Monro. Now, what are the indications? The indications are the first thing that you want to be sure of. Both of these corridors, the transchoroidal and the subchoroidal, they are for middle and posterior third ventricle. They can be used for other approaches as well. We are going to discuss that briefly, but this is mainly an approach of middle and posterior third ventricle, or sometimes the roof of the third ventricle lesions. So we want a strictly midline third ventricle lesions. They can be colloid cysts, craniopharyngiomas, subependymomas, you name it. And yes, they need to be middle and posterior third ventricle lesions. For anterior third ventricle, we have different approaches, which are not our topic today. And interestingly, even though we have discussed this in a previous session, that when there is hydrocephalus, we would prefer a transcortical corridor, primarily because the interhemispheric fissure dissection will be easier if there is no hydro. But when there is mild hydrocephalus, mild to moderate hydrocephalus, you can go via interhemispheric corridor, because what happens is once there's CSF pressure inside the ventricle, it is going to stretch the boundaries. When the boundaries are stretched, it's naturally easier to work along these corridors. Am I making sense? Anybody?
Yes.
Okay. Think of it as a balloon. For example, if there's water in the balloon, the wall is going to be expanded, and then it's going to be a lot easier to open and to separate very delicate tissue boundaries, which will not be as visible if there is no hydrocephalus. So if there is mild to moderate hydrocephalus, you can consider going anterior interhemispheric, transcallosal, and then transchoroidal approach for the third ventricle. You can consider that. But if this is moderate to severe, then it was not advisable, because then in moderate to severe hydrocephalus, the ICP is going to be really high, and the interhemispheric fissure dissection is going to be really, really difficult for you. So that would be counterproductive. But as long as it is mild to moderate, just some ventricular dilatation is there, we can go via the transchoroidal approach safely. Let's move on to the contraindications. Sorry for a lot of interruptions today. If a lesion is extensively lateral, if there's bilateral involvement, and if it is not completely midline, you know that there is expansion into the lateral regions, which will be difficult to excise from a midline approach. That is a contraindication. Some surgeons treat it as a relative contraindication. Some treat it as an absolute contraindication. Apart from that, if there are slit-like or narrow ventricles, then till anterior transcallosal you would be able to do, but transitioning from the transcallosal to the third ventricle would be very, very difficult, because the foramen of Monro will be narrow, and since there is no hydro inside the third ventricle, even the roof approaches, like the transchoroidal or the interfornicial approaches, they will be really difficult. So slit-like or narrow ventricles, they are a contraindication, because then when you're dissecting along the tinea fornicis, you can accidentally injure the fornix. Also, if there is prior fornicial injury, or there is already an involvement of fornix due to the pathology, you would not do this, because even though this is a safe approach, it still places the fornix at risk. So if there is prior fornicial injury, you're not going to do it. Let me make one point. If there is ipsilateral fornicial injury and the other fornix is intact, the neurological deficit is not going to be significant. If both of the fornices are damaged, then there will be anterograde amnesia. So even if you are going via the transchoroidal approach, you end up, God forbid, injuring the ipsilateral fornix. The other side is normal, then the patient is going to fare out normal. If there's already injury, then it's like the second hit phenomenon. One side is already injured, you injure the other side as well, and now there's bilateral injury. Let's move on. This is the subchoroidal corridor. If you understood the transchoroidal corridor, then the subchoroidal is going to be a breeze, because we are just opening the tinea thalami, right? Let's go back very quickly to all these images. If I were to do a subchoroidal approach, I would open this region here instead of this. This is the only difference. What is the problem going to be? The problem is that the working angle is going to be very, very narrow. And the other problem is, let's look at it, in fact, on the slides. So what we do is, when we do the subchoroidal approach, we open up the tinea thalami, and we retract the fornix and the choroid plexus, both of them medially. So if there is a lesion which is inferior to the choroid plexus, or if there is a lesion which is, pushing the choroid plexus superiorly, any lesions of the third ventricle floor, because this will provide a very deep trajectory. And if you want to protect the fornix, if patient had the condition that we were discussing before, one side of fornix had already been injured in whatever the reason was, you want to protect the fornix, then this is a superior approach in terms of fornicial protection. The problem is, what was here, if you look at it, there will be some portion of the deeper veins here. Once you go down deep this route, you're more likely to injure, let me see if it is visible. You're more likely to injure the thalamus-striate vein. You're also more likely to injure the deeper veins, the internal cerebral vein as well. So if the venous anatomy is favorable, you are going to do it. If the venous anatomy is not favorable, then you would avoid it. Apart from that, if the lesion is already involving thalamus, or it is highly adherent to the thalamus, then you would also avoid it. Or if the lesion is huge, looks hemorrhagic, or looks vascular, then we tend to avoid the subchoroidal approach. Why? Because the working angle will be very, very narrow and you won't be able to secure the hemostasis if it need be. There is a third option that I am not going to discuss in detail today. That is the combined approach, but you should know that this is a possibility as well. Combining both the corridors. Why? Because if you open the tinea fornix and the tinea thalami, it gives you more space to mobilize the internal cerebral vein. So this is a combined approach. It can be used. Surgeons who are very experienced in neuroendoscopy, they sometimes open up both of the corridors. This is a very quick comparison so that you can take away something from today's session. For transchoroidal approach, tinea fornicis, the medial side, is our go-to area. This is what we open. For the subchoroidal approach, we open the tinea choroidea or tinea thalami. It's the same thing, just different names of the same thing. For the transchoroidal approach, you retract the choroid plexus laterally. For the subchoroidal approach, you retract the plexus and the fornix medially. Transchoroidal is a natural corridor. Always remember this. This is a natural corridor. So because this is a natural corridor, it is going to provide more surgical freedom, especially the midline landmarks. Subchoroidal is slightly paramedian and it is not a natural corridor, so the working angle is going to be very restricted. But transchoroidal puts fornix at risk. Subchoroidal can put the thalamostriate vein and other deeper veins at risk, but it's safer for the fornix. And obviously, transchoroidal is a natural anatomical plane, which subchoroidal is not. This is a beautiful, beautiful image from Roton. And why? Because you can see the transchoroidal approach being done here. The tinea fornix is open till here, and fornix is being retracted medially. The choroid plexus is being retracted laterally. And if you see, if we continue our dissection in this direction, you will be able to expand the foramen of Monroe. And if you look deep enough, some portion of the velum interpositum is visible here, along with the deeper veins. Is it clear?
Yes.
So if any of you have time, you can spare like 30 to 40 minutes, then I would highly recommend taking a look at the third ventricle chapter, the lateral and the third ventricle chapter from the Roton, even if you can't find time to read the entire text. It would still do you really, really well if you can just look at the pictures. The pictures are beautiful and they are pretty self-explanatory. What happens once we open the entire third ventricle? You can see, because we are looking at the middle of the third ventricle, you can see the mammillary bodies. You can also see the infundibular recess. What was this between both of them?
Tuberous cinerarium.
That's right. I'm so proud of you. This is tuberous cinerarium, where we can do the ETV. We have the infundibular recess, we have the chiasmatic projection inside, the chiasmatic recess, the lamina terminalis, which is the anterior third ventricle approach. We will do that someday too, inshallah. And then we have anterior commissure here. This is the view of the middle third. How do I know that? And there's one thing that is not visible here, the interthalamic adhesion. If this was a view of posterior third ventricle, I would have seen another important landmark. What was that?
Sylvian aqueduct.
That's right, aqueduct of Sylvius. We would see its opening. We would also see some portion of the posterior commissure. So we know that this is not posterior third ventricle. It's also not anterior third ventricle because you cannot completely see the lamina terminalis. Even though you can have some appearance, you know where it is, you cannot completely see it. If this was a real patient, you would have only been probably seeing it till this portion, or maybe even a smaller view, and because you cannot open the entire fornix like this in a living brain. But this is a very beautiful view of the middle third ventricle. This is an illustration from the roton, which depicts the transchoroidal approach. There's nothing new here. I just wanted to have another image. Okay, what is the difference between this and this? This image, the first one, and these. Which view is this?
Posterior.
That's right. This is middle to posterior third ventricle. Some portion of the middle you can't see because the massa intermedia is visible. The mammillary bodies are visible. If you go deeper, you can also see the tuberoscenarium and the infundibular recess. But obviously for that, whatever magnification you're using, you would have to zoom it in. But apart from that, you can see on the second image, the aqueduct and the posterior commissure, the habenular commissure. See? While we were at the transchoroidal approach, I wanted to add something as well. I am audible, right?
Yes.
So we know that the choroidal fissure, which is this, by the way, you would have to imagine it behind the internal cerebral vein. The choroidal fissure is continuous around the atrium, right? When it is continuous, obviously the choroid plexus is continuous as well. You can see the continuation behind the internal cerebral vein. So if I am going posteriorly, dissecting this thing open, let me use different colors. If I am dissecting only this portion open, then I will see the middle third of the floor of the third ventricle, or the middle third ventricle, right? But if I take my dissection even posteriorly and open it up, interestingly, I would land in the quadrigeminal cistern and the pineal region. Are you getting why? Can you see this continuation here? Usually in the normal subjects, this is closed, right? But if you open it up deep enough, you are going to land into the quadrigeminal cistern. Let's look at another image. You can now see that this is the same image, it's just zoomed in. And if you open along this region here, this is atrium, by the way. If you open along here, you are going to land into the pineal region and the quadrigeminal cistern here. So this is another roton illustration. You can see that this is the atrium of the lateral ventricle, the choroid plexus. They have opened up this space, and what you can see here is the quadrigeminal cistern and part of the pulvinar. If I go even deeper, I'm going to find the pineal gland. If you understood this illustration, it's well enough. If you don't, it does not matter, because this is just something you should know, that transchoroidal approach can be used as an extension, and you can extend your surgical exposure to the quadrigeminal cistern as well. That's it for today. This is a wrap. Please let me know any questions, any feedback on the group. I'll see if the live version recorded everything I said. Otherwise, I'll just edit the recording and put it up. Thank you so much. This is a wrap.